Good evening. Hi, for those of you that I don't know, my name is Don Elliman, and I am in the very fortunate position to be the chancellor of this campus, which is a blessing and one that makes me put a smile on my face every day when I get to come to work. It's a great place, and I'm lucky to be able to represent it. This is part of the Transforming Healthcare series, and I thank you all for being with us tonight. We're going to talk about orthopedics. You know, we're running an ad campaign for the campus, actually for the first time ever now. And the theme is this is breakthrough, because that's really what this campus is about. It's about redefining what healthcare is going to look like in the future and playing a major role in that redefinition. And you're going to hear from three people tonight who are a big part of that in the world of orthopedics. You're going to hear from the department chair, who is, by the way, one of the stars of our ad campaign, although you wouldn't know it because she has a mask on in the picture. So, but if you pick up the New York Times one day and see a photo of a surgeon with a mask on, that's in fact our first speaker tonight. And then you're going to hear from people working in the field of regenerative medicine in orthopedics, and finally, or I'm not sure what the order is, from one of our surgeons who is actually just now exiting the OR, who has developed a procedure that will be, and doing it for the first time in this country to help people who've had amputations. So I hope you enjoy it. One word of warning, this is orthopedics, and you will be seeing some pictures that might make you a little queasy. So feel free to look down or sideways or any way you want. But I think the stuff that's going on here, I mean, when we think about the evolution of healthcare and the rather dramatic pace that's taking right now, we tend to think of areas like cancer and others that are obvious. What's really exciting is that the very same thing is happening in orthopedics, and we're proud to have the leadership team that we have here to be playing a major role in that. So with that, I'm going to turn it over to the chair of the Department of Orthopedics, Dr. Evelina Berger.
Thank you, Don. Thank you. Well, good evening, and thank you very much for everybody that showed up on the first Monday after daylight savings time at the right time. So that is really, they say that this week actually sees an increase in car accidents just from the change in what we do. So please be safe out there. Okay. Tonight we want to show you where orthopedics is heading to. Orthopedics started, and I think it's in the mind of everybody, as the care of the crippled child. And it was always the tree that was lightly wrapped with bandages and the stick that keeping it up straight. And I think that a lot of people still have in their mind that orthopedic surgeons take care of the crippled people in our society. Fortunately, that word has also disappeared in our vocabulary. And orthopedics at the moment is at the cutting edge of keeping us young. Medicine has figured out how to keep our hearts going. The transplant surgeons are transplanting every organ that we need. We cannot transplant bones. So we are in a big challenge with our aging population and also with the high demands that our sports people have on them today versus 40 years ago. So we want to give you a little insight into something different than just the care of the very sick people. So I'm very blessed to be the inaugural chair of the Robert D. Ambrosia Endowment, who started this department after it was on probation 13 years ago. We are also fortunate to have a previous chair in our audience tonight, Dr. Jerry Wiedel, and thank you for being here all the way from Steamboat. Okay, that's it. So the department started out from a very small place to now having 62 surgeons, 4 podiatrists, 55 APPs, which you know as nurse practitioners and PAs, 10 PhDs, 40 administrative staff. We are in 18 sites of practice in Colorado, and we garnered $14 million in federal research grants this year. We oversee 50 medical students, residents, and fellows annually. Our subdivisions and sections, as the Regents wants us to name it is spine, where we have 9 MDs and 6 APPs, hand 3 MDs, 1 APP, foot and ankle and podiatry with 3 MDs, 4 podiatrists and 3 APPs. Sports medicine, we have 15 MDs and 12 APPs. Musculoskeletal oncology, 1 MD and 1 APP. Joints and adult reconstruction, 5 docs and 6 APPs. Trauma, 3 MDs, 4 APPs. And pediatrics, 23 MDs and 22 APPs. So really a big department. We are blessed that we have every discipline represented in our department. Tonight I'm going to tell you a little bit more about the spine division. In spine, we have a team approach. We try to pre-optimize our patients. We have specialized spine anesthesia providers, and neuromonitoring has made bounds and leaps in terms of safety and what they can tell during surgery to prevent harm and paralysis. We have a co-surgeon approach that we started about 15 years ago when I came here, and I remember I told my partner, Dr. Patel, we should write this up. And he goes like, no, they might think we're too stupid to do it on our own. Well, now every article you read is about the benefits of co-surgery in these big surgeries that we do. So we were ahead of the curve, but we didn't even know it. We are doing a lot of outcomes research and a lot of innovation throughout the department, but also in spine. The picture here is Dr. Kleck, who is our new section head, and myself with a fellow doing a surgery. So this is what comes to mind when you look at spine. You think about these patients that are severely deformed. This is a 32-year-old female with 137-degree kyphosis, and as you can see, no teeth. And you read about these poor women who gets abducted and gets locked into basements, and for years, this patient was one of those. And when she was finally released and her parents found her, she was brought to us. She had traumatic brain injury from all the beatings and all these fractures, and nobody wanted to do anything for her because of her traumatic brain injury. She was actually very intelligent, and this is the new software we have. We can actually take these x-rays, which is also new. It's a 12-second x-ray, and you can take a full body view, frontal and sideways, and we can accurately measure this. In the old days when I trained, we had to do it with a little protractor, thank God. And then we have this computer program where we can actually simulate what is the type of surgery that we need to do to get to correction. We then order the rod for the patient specific, and then we can do the surgery. There's the rod that we ordered, and we get the result that we wanted. In the past, you would take this patient to the OR, and you would pray for this, and if you got 50% of that, you would say, oh, great result, okay? Now we can be accurate and meticulous and hopefully prevent complications and long-term complications. And I've done this for 23 years, and I can tell you this has made a huge difference to know that when the patient lies down on the table, when they stand up, they will be standing up straight. Before it was an art, now it's a science. So I want to show you what we usually do. This is another example of a patient that had a chin on chest deformity that we were able to cut out some of the vertebrae and get the head up straight. This is a patient who had a massive cancer that wasn't sensitive to any radiation or chemotherapy. And we took out everything, the whole spine, and this is the aorta that we bypassed. We also had to take out the aorta. And this patient was able to get off the table and walk. And this is an example of a patient where we are actually taking out a piece of a vertebrae. There's the spinal cord with the nerves. So you can see a lot of carpentry. This little picture here is to show you what we had before. This is the standard rods that you would find in any company's sets. Since we started to plan this, we also started to plan single levels, and you can see how big a difference that makes, and which tells us that we were responsible for causing a lot of the harm of patients that had initial surgery and then had failure 5 or 10 years down the road because we didn't get their posture corrected even on a single level fusion. So today we are here to celebrate somebody really young and to tell you this is a paradigm shift and that we can also help the very young. We have patients that are born with deformities that our pediatricians take care of, but we increasingly find a number of our teenagers and young adults who have high demands, as you all know, that have kids or grandkids. They all belong to some kind of club where they play some kind of sport, and it's very important to be top of the line so you can get a scholarship to go to college. So we find that there's a lot of stress that's being put on the vulnerable spine of the teenagers, where they will be doing things that their spine is not ready to do yet, because your spine only stops growing at age 24. And one of my colleagues tonight will talk about what this does to their knees and stuff like that. But for the spines, we also see dramatic changes in a very young population. So Maritza came to us as a 19-year-old adventurous and top athlete. In October 2017, she had debilitating low back pain and buttock pain. She was unable to participate in sports. She was in college with a volleyball scholarship. She played lacrosse in high school, very active skier in the community, lives in Steamboat. And now she's first year in university and she cannot even sit in class, let alone compete on the volleyball team. So she had very little treatment offered to her. And the treatment that was eventually offered was a fusion in a young surgeon. So her dad, being the former chair of our department, phoned me. And I said, yeah, when she comes home for school break, let's take a look at her. So this is what we found. This is Maritza's x-rays, which, if you look at it at first, looks very normal. No instabilities, great motion, great disc heights. As you can see, these are the discs. Those are the vertebrae. It looks like a perfect spine. If you do an MRI, you can see that she has this, all the discs are white. They look like little fishes. Over here, it's black. And you can see there's a piece that's protruding. And this is a cross-section of that little piece that's protruding. That's in 2016. 2017, the MRI looks basically the same, but a little bit more of a protrusion. So I want to pause here and tell you guys that a lot of herniated discs, you herniate your disc acutely, it pushes on a nerve, and you can barely walk. You get severe spasms, pain radiating down your leg, and it's a terrible pain. People will lie in a bundle because it's so pain, it's neurogenic pain. But the main function of the disc is to be your shock absorber. And if you lose the ability of your disc to be a shock absorber, every motion you do is painful. Whether you sit, stand, even if you lie down, you have a baseline pain. And a lot of our young people and patients with this disease have been branded as malingerers because their MRI looks like benign, the x-rays looks okay, but you need to listen to these people. They are debilitated with chronic pain. And in the old days, we used to say, okay, you have a bad back, so we'll give you a sedentary job. Worst thing we'd ever have done. Of the 4 activities that we do, standing, sitting, walking, and lying down. Sitting puts the most stress on your disc. So the worst thing you can do for somebody with a back problem is to give them a sedentary job. Okay? It's better for them to walk. Standing is next to sitting, so it's sitting is the worst, then standing, and then walking. So they're much better off if you can give them a job where they walk, just FYI. So Maritza looked like that. She was really desperate. Her dad was, however, trepidatious. We had to convince him. We did a CT scan, which showed that she had perfect joints. There was no sign of any arthritis in her back. A beautiful, young, pristine spine with a malfunctioning disc at L5S1. So every movement for her was painful. We decided to offer her a disc replacement. This is the surgery for disc replacement. It's a small incision. You can make it horizontal, you can make it longitudinal. And we do this through the abdomen. And so all of the intestines is in a sac called the omentum, and that gets pushed to the side. And this is what we call a retroperitoneal approach. It's the same place where your nerves and your kidneys sit. And then we finally get to the disc after we take care of the vessels. There are quite big vessels in the front, the aorta and so on. So then once you see the disc, it presents like this. You can make an incision in the disc. You clean out the disc, and then you want to size the disc. Here you can see we're coming in with different sizers. And this is the critical part, so you don't put the disc oblique or like that. It has to be nice and in the center. Lots of x-rays involved in this. This is, again, the trial implant. You have to be completely midline. This is pictures from Maritza's with the needle in the midline, sizing the disc, making sure that we will get it in. And this is her disc in place, picture taken of her during surgery, okay? So it went well. We did the disc replacement for Maritza in March 2018. This is her disc replacement. The rehab is completely different. We don't want people to not do anything. We want them to move as much and bend forward and stand as much, because you want the end plates of that disc to really embed in the bone. So very important. This is the intraoperative view. You can still see the retractor frame here. So I told Maritza, this is what you have to do. 3 months post-surgery, she came back, we took an x-ray, we were very pleased with the placement. And we can also see that her disc was moving well in terms of opening at the back when she bends forward, and then when she goes back, there was great motion. So we didn't fuse her back, and that didn't put an extra load on the others. So surprise, 1 year later, I get a Facebook text. And I go like, what? And this is Maritza, and she is on Everest. She's at base camp at Everest. Didn't come back after 3 months, didn't see her. This is the very next follow-up I get, okay? And I go, holy moly, hope she knows what she's doing. But anyway, so this was Maritza 1 year later. She's now back to full function, and we'll get her to say a few words. She loves to hike and camp, as you can see, on high places. I'm afraid of altitudes. I want to point out why this is successful in a young patient. We presented this project early on in 2011, facet joint biomechanics at the treated and adjacent levels after total disc replacement. We also received the White Cloud Award for the best paper at the Scoliosis Research Society. And we could demonstrate that rotation, for all the motions you do in your spine, this is rotation, this is forward flexion, is the most demanding of the spine, is rotation, and that there's an increase in the facet forces at the treated level after the disc replacement. But we were also the first group to show a decrease in several biomechanical parameters after total disc replacement at the adjacent level. And that's the big difference. If you perform a fusion on somebody, that part of the chain is fixed, and the next level of the chain needs to move double as fast or as much to accommodate your motion, because you don't want to be stiff. And that actually leads to increased work of the disc above. This does not happen in total disc replacement, and that's why we do not have to limit the patients in that sense. The level of the disc replacement, there will still be arthritis and wear on their joints, but we don't know when. We've got disc replacements that are now 10 and 12 years out, where the patients do not have any issues. So Maritza, I hope it's going to last you for a long time, okay? So here she is in full swing, howling with her dog. It's a good thing to do. Climbing a mountain again, skiing, alpine skiing, scaling a rock, on top of the world, scaling some more rocks. So just in summary, the intervertebral disc is the shock absorber. It limits your motion, and it's a uniform internal distribution of the load, and the pressure is in the disc. This is the nice inside nucleus pulposus. And as we age, unfortunately, this is where we start with a normal disc, and then we get a little bit brown, and then we get a little bit deranged, and then we get a little bit creaky, and finally we look like grandma, okay? And that's going to happen to all of us. So we lose the water content The proteoglycans and the cell viability diminish, and there's a more acidic environment. And then the keratin sulfate increases as well as the lactate in the disc, and then there's a lot of enzymes that breaks the disc down, and eventually we form scar tissue. So we all start like this, and we said, I'll be back, and unfortunately we end like this and say, oh, my back, okay? And that's the natural progression of this disease, okay? So what are the advantages? In a fusion, we stop the motion between two segments. This leads to increased stress on adjacent levels. It takes 6 months to heal. It's indicated for severe degenerative conditions and instability like grandma's disc. Disc replacement is indicated for relatively normal facets, no instability. It's much earlier in the disease process. So the paradigm is shifting, where people would suffer for 20 years of their severe back pain, then come to us. If the discs are already done, then their facet joints are injured and we have to do a fusion. Disc replacement is for the young at heart and the young spine, okay? Quick to recover and better functional outcomes. And with that, I want to say thank you very much, and I want to call on Maritza to say a few words about her back. Sorry, I'm putting you on the spot.
That's okay.
I'll stand with you. And Maritza is one of a twin, identical twin.
Yes, I have an identical twin sister. I'm Maritza. So I guess the whole experience was great. The rehab was awesome. After being through a year and a half of just constant pain, I was just excited to start something new and to get back at it. So I can't play volleyball anymore. Well, because I was out of it for a couple years. And at the collegiate level, you sort of lose your talent, or maybe not talent, but the muscle memory. It was kind of traumatic psychologically to have to dive for balls on the ground when you're like, that hurts so much before. But so far I've been in complete recovery. So I ran an ultra marathon 2 weekends ago. And so I am working with Ski Patrol this winter at Ski Cooper. I can lift again. I'm just fully recovered. It is great. And I have not had any pain, so it's great.
You're awesome. I also want to shout out to her because a lot of this recovery is her motivation. And so it's critical, as we know. We are all involved in mental health, and if we have patients that have a good mindset, that want to get better, it's easy for us to do the right thing, and they will do the rest. So congratulations. Thank you very much for being here.
Good evening, everyone. Well, it's truly great to be here, and I'm truly new on campus, so it's great to meet all of you for the first time, and so I'm so excited to be here in so many different ways, and I think this really shows the potential of what's going on here at CU. I could tell you Stanford's a wonderful place, and we made a lot of progress. But I can tell you the potential here and the colleagues that we have here are honestly on a different level in a lot of different ways. And so I'm so excited to be a part of this team today. And that's one of the things that I want to communicate. The other one is this. I can't tell you how many times that I sat late at night in the laboratory wondering if nights like tonight would ever exist. Wondering if this regenerative technology would ever get to the point that we could help humans with it. Because in the laboratory, it's really exciting. There's lots of things, but really to help someone and to be able to make a difference in someone's life, that's what it's really about, I think, with science. And the good news is today is the day that we really have this technology with us. And tonight I just wanted to tell you a little story. I'll pass this to the story of how it all began for me, because in a way it's kind of a crazy story. So I was part of the original team that really discovered the stem cells within fat tissue. And it was a crazy time very early in my career. CNN and all the news folks were flying around and interviewing. It was a crazy time. And I was the youngest member of the staff at that point. And so we quickly had to A, celebrate, and B, figure out what the heck are we going to do next. And so the leader of the team said, okay, well, everyone's going to do your job. Jason, your job is to take these cells and make them cartilage and bone. Good luck. And I said, well, I have a few questions, right, on how to do this. Do you know how to do it? And so right away, I was on my own on this expedition. And at the time, it was breathtaking, let's just say that. But now is one of the best experiences in my life. And I think that's when you really have to look inward and really say, okay, I've got a big job to do. How are we going to really get it done? And so really, that's how it started. And our first job was to figure out really where the cells were, because we knew that the cells were there, but we really didn't know how to find them. And if we were going to create a technology to be able to use them, we needed a lot of them. Well, the good news is, as humans, a lot of us have a lot of fat, so that's good because there's plenty of donors, right? So that makes people happy. But what we found is that these stem cells are everywhere. And everywhere, not only through the fat tissue, but in all tissues, and they tend to really mingle around the blood vessels. And that's such a great design by Mother Nature, because if they're there, it's really easy for them to detach and then go into the bloodstream. And so then we can use them at distant sites if our body calls for that. So kind of a brilliant design. So that was the first thing of understanding where we need to look for these cells. And that was its own little lesson. The second lesson is this, and Dr. Berger talked about this already today, is that we had all these preconceived plans about how these stem cells were really going to make cartilage fast, and it turned out that it wasn't always true. And then we realized a couple of things about these cells. Number one, our bodies age, and guess what? Our stem cells do too. And if we all think back about how it was to be a child or even look at children, and if they're ever injured and sick, how long does it take them for the most part to come back? Just like that. In orthopedics, we really know it because if you have a broken bone, oh, it's good enough, it's going to heal. And it's true most of the time. But as we get into adults, and I know Dr. Stonebeck is going to talk a little bit about adults and how it's much more difficult for adults to heal their wounds and their bones. But a cool thing happens, right? A cool thing happens in life. Let me flip the paradigm a little bit and say, well, what would it be like if you were going to be a physician or an attorney when you were 10 years old? That'd be tough. So we have a lot of good things that happen to us in our body. We became much more expert and able to do things in life and to think. And so the same thing really happens with our cells. And we didn't know it really at the time, but we called them stem cells from fat, or these adipose-derived stem cells. But in truth, when you look at it, they weren't even stem cells at all. They were really best called progenitor cells because they were too adult-like and they couldn't make every tissue in the body. And so they didn't even meet the definition of stem cells. And so here we have every billboard, seemingly almost in every block in commercials, talking about stem cell therapy. And I think those same docs are talking about adult stem cell therapy. But in reality, it's not stem cell therapy, but they can do some cool things because we still can make these cells turn into different tissues to help us regenerate the body. And that's what our research is about. So you might have this question about, well, why do we talk this way? Like, why do we really still call it stem cells? And I think the answer is because now it is so pervasive out there that that's what people know. I want stem cell therapy. And it reminds me of this conversation I had with my patients because we're trying to toe the line responsibly. And I said, well, sir, it looks as though your knee has been injured, and I think you would be a very good candidate for progenitor cell therapy. You say, Doc, thank you very much. You've always taken really good care of me, but I think I'm going to stick with the stem cell therapy instead. Okay, well, this is here to stay. And that's the reason you still hear the language as you hear it on the billboards and in medicine today, even though it probably is best termed modern day cell therapy rather than stem cell therapy. So some of the lessons learned. Well, without that black line through it, this is what I stared at the beginning of this expedition. And I spent weeks, months, and even a couple of years staring at the same slide, trying to go over what would it really take to change these cells into something that we can use clinically. And I do have to say that I'm going to fast forward this story 6 years, right? But after 6 years of a lot of trial and error, something miraculous happened. That these same cells turned into a very different tissue. And for those of you who have not seen cartilage before, this is what cartilage looked like. And you see the power that is in regenerative medicine. There's no better example than this, of something that is plain Jane and doesn't really look like anything, and how it can change over time. And all we have to do as science is really figure this out, right? And if we control this process, we can do a lot of great things, including having our own bodies heal themselves. So step number 2, well, if we figured it out in a test tube, how can we start helping folks? This was the original trials on helping injured animals. And so then you see an injured animal here, and here's where it looks like. This was a pre-surgery of an animal with an injured knee, in the same way we have it with as horses, and the same thing with humans. And you can see how then the cartilage is regenerated on this particular animal here. Fascinating. Fascinating technology. Right? And so then it's to the next point. And the next point is, well, how can we do this in humans? And like I said, the time is now. All right, so here's an actual surgery, and here's an actual hole in the cartilage of a human. And this is our technology now, in case you were wondering, what is this surgery like? And so this is me here putting a special little bit of biologic glue at the base of where our bone is at the bottom. And then what we're going to do is pump in this mixture, and this is cells that have been harvested during surgery, that have been processed in the operating room, and then placed back into the defect. And you see how we're just placing this in anatomically to the point that there's nothing left, there's no more hole left. And so what we're going to do is make sure that this is tucked in as possible, and then I'm going to lay down another layer of fibrin glue. It's kind of fascinating. It creates a cocoon and a living environment for these cells to proliferate and to grow in the human body. So this is what it really looks like, and we allow the glue to dry, and then the patient can go, and it's day surgery. And this whole process takes about an hour and a half to completely do this. So from time 1, you can see the difference, right? From time 0, right? You can see the difference that it makes dramatically. And as we're going on here, you can see the difference it makes. So you can only imagine that this was a hole in the cartilage where the arrow is, and you see that at a very early time, look how quickly this is healing. So only 8 weeks. And here's 2 years, and you see that the cartilage surface has reformed, and it's healed to the underlying bone. It's really fascinating. So we're so excited in the power and the potential of this, and we're so excited to continue studying this at CU here. So we have a special treat, and if you guys would mind welcoming David to the stage here. David is our very first trial participant here. He's the first to have this sort of technology in his knee anywhere in the world. This is a very small invasive approach. So thank you very much for joining us. It's really great. And so it's great because you were the very first, and I can only imagine what that feels like when somebody comes up to you with a lot of options and on things to do, and we've been through a lot together here. But can you take us back first and tell us a little bit about what happened to your knee and why we needed to fix it?
Hello? Can you hear me back there? Okay. So at the time I was 27 years old when this happened. I had fallen snowboarding. And, you know, my activity level, I was in the best shape of my life. I just did an Ironman the year before. I was basically on top of the world. And then all of a sudden after this fall, I got a little hole in my cartilage. It was underneath my kneecap in the trochlear groove, which is on the top part of your knee. And it's what your kneecap slides in. At the time, I spoke with a bunch of doctors, and basically they all told me that if I don't do anything, it'll lead to bone death, and that eventually I'll need a total knee replacement. but they also said I was too young to get it at the time. So basically, they said just get some new hobbies and be on your way.
So David came in, and he was having trouble with his knee. So, and thanks for bearing with me on this first meeting, because we went over a lot of options, right? There's a lot of different ways to help regenerate the knee, and we were trying to do something new. We were trying to use your own tissue, right? So tell me about this decision making you had, because you're a very intelligent guy, and you've done a great job, because before he was even in the clinic with me, he did a lot of research on the options, who is very educated on the different options. So tell us, how did you make the decision to be a part of a trial and to try something new, such as regenerative medicine?
Hello? Okay, sorry. Yeah, so basically I had to first define what is a success for me. When you look at a lot of these options out there, like they do micro drilling or knee replacements and things like that, their definition of success isn't success for me. Basically, most people don't even do anything but walk. So I didn't want to just walk the rest of my life. So I eventually whittled my way down. I gathered a lot of information, and I finally figured out that this stem cell thing might work. So that's how I found Dr. Dragoo, is by researching it that way. So three things eventually got me to this option. I had to ask myself, first of all, what do I love? And what I love doing, stem cells give me the most potential upside for doing that. Also, if the treatment didn't work, I could do multiple other treatments after that. And then second was what we already discussed, where basically I didn't think the science was up to par. I didn't for the other surgeries. I didn't think that their definition of success or how the surgeries were performed were up to par either. And and none of them really gave me a chance to get back to sports that I love doing. And third was that not only did these stem cells come from my own body, which meant that it reduces complications dramatically, but it also means that as long as I still have stem cells in my body, I could potentially get this surgery over and over and over the rest of my life.
Hopefully not.
Well, hopefully not, but yeah. So, I mean, how many of you have joint problems or known someone with joint problems? I imagine that's most of you. These types of treatments could effectively lead to curing many problems with arthritis as we know it, and could dramatically improve the prime years of somebody's life.
Yeah, well, that's great. So tell us how this went. How did you feel? How do you feel now? I think everyone's really interested how this went, especially you being the first one in the trial.
Yeah, so first of all, it was a double-blind study, so I had no clue I was the first patient in the trial. But I did know that it was it was one of the first trials of its kind in the U.S. or the world. So I thought that was pretty cool. You know, I'm really glad that I could help further medical science, and really hope to help others out with this data that they collect. You know, these studies involve a really rigorous process with a lot of intelligent people, a lot of really caring people. And so I wasn't really worried about the risks of the surgery, because I knew everyone was trying their best to help me and to heal others, which is important. I was more concerned about just sitting around the rest of my life and doing nothing and not being physically active with my legs anymore. So yeah, I mean, I just want to say, if any of you ever had the option to or need to, I highly suggest that you be a part of a study like this. They can really help people out and may help you.
How do you feel?
Yeah, and then ultimately, today, the way I feel is really good. So I went through surgery. There wasn't any major complications. There wasn't any infections or anything like that. Approximately a year afterward, I don't think Dr. Dragoo knows this, but I had signed up for an Ironman Lake Triathlon in Alaska. So I did half of it. So I swam 3 miles and biked 60. I didn't run because I wasn't allowed to. And and then I had a good lunch afterward. So and the knee's still working really well. I don't have any pain associated with it. I have a little bit of crepitation, which is just a little bit of bumpiness, and I don't really have any major problems with that knee anymore. So.
Well, thank you. And so one final question. So what was it like to be first at something, because I just want to try to bring this out, because I've never done that personally. And I mean, I put the trials together, but I'm not the first one in line. And I mean, was this a scary thing, or were you okay with just knowing that? I know you did, it's a randomized trial, right? So you don't know what treatment you get. And so after he completed the trial, 2 years, we told him, right? So now he knows. But at the same time, was this a difficult decision to make because you were first? And if you were fifth, maybe this would have been easier for you? Or was there any trepidation about that?
Not really. I mean, it depends when you look at history, but everybody has the first person, and you have to be, and occasionally you might have to be first in line for something. You know, I looked at my situation kind of as a holistic approach. I grew up with somebody that was, you know, quadriplegic, couldn't even move. You know, I did an Ironman the year before I hurt my knee, and I saw a guy with no leg do the Ironman, which I was really impressed by. So when I looked at my situation, you know, I had a little piece of cartilage the size of my thumbnail missing, and it wasn't that big a deal for me, ultimately. And I wasn't going to let it control my life or how I felt about being the first person. So.
Well, thank you very much, David. It's really great to hear your story.
Yeah.
It's important, and it's great getting to know you.
And thank you all for coming here and listening. So have a good one.
And I just want to tell you, just in wrapping up here before Dr. Stonebeck comes up, how things are different here. And this is the way we approach medicine. The way we'll approach regenerative medicine is different, again, than many other clinics, even here in the Denver area. And what we are trying to do is we're trying to ground the techniques that we are practicing and that we are coming up with and creating, grounding it in basic science. And these numbers don't mean anything other than to tell you that we've done the homework. And so we know where the cells are, how many there are, and we've then tried this technique in the laboratory, et cetera, to have a baseline of understanding of how this is going to go. And then the final is performing trials, and this is what David was talking about here. We believe in studying every patient that comes through the door so we can then continually get better and better with our technology as time goes by. And that's a very much of a differentiating factor here at CU. And it's amazing from the regenerative medicine how many practitioners we have in so many different areas of medicine. And it's great to have everyone band together in kind of this new area of regenerative medicine. I think it's really going to be a standout here being at CU. I know many of you are wondering here, what's the punchline? What can stem cells do for me in modern? And I think that we can really talk about these three things, right? That if you look at, quote, cell therapy, almost every single study in orthopedics, almost every single study shows that people get pain relief, and I'm going to show you why. The second thing is that the cell therapy is very intensely anti-inflammatory. So that's benefit number 2. And what we're trying to research here is number 3. This is hot on the list of our trials that are going on right now. Can we actually regenerate the tissue? It's one thing to fill up a hole in David's knee, but can we resurface the whole street? Can we take osteoarthritis and make the knee young again? Well, I don't know. We're trying. I could tell you that we're trying. And I think here's the summary statement of modern day understanding of the cell therapy within orthopedics. Cells can relieve pain, believe it or not. The basic science shows that they activate opioid receptors. And it is the most likely link to the pain relief that's generally perceived by most folks who have it. So it's interesting, and that's why probably it's so powerful. The second, its anti-inflammatory effects are because of the modulation of the immune response of the body. And so the body likes to make a big deal of things and cause a lot of swelling, and so the cells then decrease that body's response. And so that's what, the most likely reason that they're anti-inflammatory. And so the question in 2019 is, can it really rebuild tissue? And can I say I don't know? But can I show you this? This is another slide of resurfacing the street from Korea. This is 18 patient study showing bone-to-bone arthritis. The pavement's back. And we can show you, again, their follow-up MRIs, et cetera. All it is a proof of concept that there's something here. And you can see then the enthusiasm of regenerative medicine as a whole. So the future is bright here at CU. I'm so honored to be a part of the faculty here. Thank you very much for hearing my story. And next we have a really exciting presentation by Dr. Jason Stonebeck, who also is leading the world in new technologies for amputees, et cetera. So I can't wait to hear his story as well. So thank you very much.
Let me introduce another Jason. This is Jason Stonebeck, who I can say was my baby doc, which means I'm really old. Jason was my resident, and then we sent him away for a fellowship, and we grasped him back because we always knew that he has potential. Jason is an all-American rodeo cowboy. And Jason married Miss Tennessee, who is now Jen Stonebeck. Okay? So Jason and Jen still take care of all of our ropers, and they do team roping. But besides that, he's just an awesome trauma surgeon. So if you get in a car accident tonight, pray he's on call. Okay? Thank you, Jason.
Thank you. Thank you very much. I'm sorry I'm a little late. I was in surgery earlier and doing some of the surgical procedures that we're going to talk a little bit about tonight. I'm really excited to talk about this topic of osseointegration. Osseo meaning bone, and integration of the bone growing into a metal prosthesis. This is truly a game changer for amputees. And it's been a real privilege to work with some worldwide leaders. A colleague of mine, Dr. Jan-Paul Frolke from Holland, is here tonight. He's visiting us for these surgeries this week. And thank you for having me. So when I see this picture, it was like the sunset that we saw this evening, right? It's brilliant. And we have so much to look forward to. The world is wonderful. There's so much opportunity where we live. But sometimes as we go through life, unforeseen obstacles come out of nowhere. And that's what I want to talk to you a little bit about, what it's like to be an amputee, at least for some amputees. It can be a devastating injury that can lead to things that you've never really thought about, that impede your way of life and your interaction with other human beings. So I want to tell you about Mike, and he asked me to keep his name confidential, so I'll call him Mike. Mike was 15, so just like that picture we first saw, the world was his oyster. He's excited. He has great friends, things to look forward to, high school. We're going to drive, right? This is going to be great. But he started developing pain in his thigh. It hurt. At first it was just, well, maybe I pulled a muscle or something happened, or it'll go away. It'll get better. And then it didn't. And the next thing you know, it started waking him up at night. So he was diagnosed with osteosarcoma. What that is a tumor of the bone that can be life-threatening. Now, fortunately, it was caught early. He went through a lot, had an amputation in order to save his life, went through chemotherapy, was very sick, throwing up, but made it through that. So you fast forward, he's 22 now, right? That's a win, right? We've saved his life. He's doing great. No more cancer. It hasn't come back. He survived beyond 5 years. That's one of the things that we look for as a success in treating this disease. So he should be like this picture. Now, he's not in this picture, but he could be any one of these young men in this picture, right? He's out. He's socializing with others, college, job, etc., right? But that's not what Mike's life looks like. So I asked Mike when he came to be evaluated for this procedure that I'm going to talk about, and I said, what are you hoping to get from this? And he said, I really want to have better relationships. And I said, what do you mean? Because I thought, well, he wants to date more girls, or what does that mean, right? And he said, I don't know how to explain it. When I walk down the street, my leg will just fall off. He's an amputee. And he said, I don't know when it's going to happen. I had several internships, and I was walking down the street with my boss or colleagues, and my leg would just fall off. He said, it's incredibly embarrassing. And he said, so when people call me and they say, hey, Mike, do you want to go out to the movies tonight? He said, do I tell them that I'm scared that my leg's going to fall off? Or do I just say, I'm busy. I really would like to go, but I just can't make it. So that's what he does. He has that decision almost every day. Do I tell people that I can't do that, or I'm worried what's going to happen, or do I just make an excuse, right? Donna. Now, Donna is an exceptional lady. She's fantastic. When she was 31, she was involved in a severe car accident, and she had multiple broken bones around her knee, had to have multiple surgeries in order to fix this. She healed, had chronic pain, and then unfortunately, ultimately had to have a knee replacement, okay? Because of the severity of the damage to her leg and her bones, that knee replacement failed, amongst other reasons. She had 4 revision knee replacements. It had to be redone 4 times. So ultimately, she decided at the 5th time, I'm done. I've had it. Just let's have an amputation, which is what she did. So now she's 55, and this is what she deals with on a daily basis. So what she's doing is she's describing to me what it's like to get ready to go to the bathroom, to go to work, to just go shopping and get groceries. She has to put on this sleeve on her residual limb. She's an above-knee amputee. And then she has to check it, and she's saying, oh, I've got some wrinkling in there. I got to start all over. So she has to take it off, and she has to put it back on. The way these above-knee traditional sockets fit is you have to wedge your leg into it, okay? And it rests on your ischium, or this kind of bone back here, and your groin. So many patients have just their groin is rubbed raw from walking, just in a normal day. She's also telling you in the video that she said, I don't know how I'm going to do this when I'm older because my fingers, I don't think they're going to be strong enough, right? This is a device that helps create suction so that her leg doesn't fall off in time. And then she's going to get up and she's going to wedge it on. And in the interest of time, I'll probably go through this, but she's going to wedge it on and it's off a little bit. So her foot's crooked. So she has to start over. So this is an incredibly challenging thing to live with, particularly for above-knee amputees for just some of these reasons. So what these patients had was limb salvage. This is like a term that I don't like. It's a term that implies we have this garbage can with like barnacles and it's a bunch of dents, and we got it off the bottom of the ocean and we knocked the barnacles off and hey, you got a leg, right? I don't think that is what we were really looking for these patients. So here at CU on this campus, I have the distinct privilege of running this awesome program full of awesome people. It's called the Limb Restoration Program. And the reason we call it the Limb Restoration Program is it's about restoring a patient's form and function, not about just doing something or saving them. It's about making them be back to their optimal selves or whatever that may be. We take care of a whole host of conditions, from tumors to bones that don't heal or bones that heal crooked. Individuals, we lengthen limbs that if you've lost bone or you've been born with a leg that's shorter than the other. And when you're doing this type of work, you have to be able to do amputations well for the patients that need it and also provide support for those amputees that are having difficulty like Mike and Donna. So here we have a lot of programs looking at how to make things better. We're great partners with CSU Veterinary School, looking at partial limb canine amputees, and how do we help amputees be restored, be their optimal selves? How do we help that? So what are the traditional prosthetic challenges? So you can see there's some pictures of some pretty antiquated prosthetics. And if you look, there's a growing population of amputees, in part because of the IEDs that we've experienced with war, airbags where people are surviving severe car accidents, but like Donna, have other traumatic injuries that we may not be able to fix. It's estimated that less than 50% of amputees return to work. And if they do, it's about 1 year to get back to work, okay? If you are a bilateral above knee amputee, 90% of those patients are basically confined to a wheelchair. Because like Donna, not only do you have one leg to deal with, you have two. So you have to wedge these on. And the energy it takes to be able to get out of just a chair and ambulate is significant. It takes a lot of effort. Other issues. So some patients have severe burns or scars, or one of the most common things that we deal with are very short residual limbs. The most challenging being a very short femur or above knee amputee. But short below knee amputees have their significant challenges with this as well. It's very difficult for these patients to manipulate their limb because you have this very short leg that's actually powering this heavy prosthesis in space. There's a lot of pistoning when they put these devices on, so they actually have sync in them. So if you can imagine pressing on the brake of a car and you feel it, right? These patients have to sink in their prosthesis, and there's what we call like slop. So they sink in it until they start actually moving their prosthesis. When you're an above knee amputee and you're trying to raise your leg up, it moves around in this big bucket, if you will, inside, and then kind of starts moving the limb. So it's very challenging. They can't feel the ground. I mean, that goes without saying, right? But imagine walking out here when, like a couple weeks ago or last week when it was snowing, or uneven gravel that just comes out of nowhere. It can be devastating. It can take horrendous falls, and it'd be very difficult. I would say the other thing that, decreased confidence in walking, and it can be just painful. So one of the most common question that some of these patients ask when they show up to my clinic, we meet them at the door. One of my team members meets them at the door, and they say, "Would you like a wheelchair, or would you like to walk to clinic?" And they say, "How many steps is it?" Imagine how many steps makes you think about when do you want to go to the bathroom. How many steps makes you think about, I have an office job and I'm able to sit, but I'm going to print out 5 jobs before I get up, and I'm going to wait till I have to go to the bathroom so that I can make one trip. So what is osseointegration? So osseointegration is that process by where living bone attaches to an artificial implant. It was originally came from dental work. So there was a screw-in device that can go into your jaw, and then it will grow into your jaw, the metal, and then we can place these implants. So that was the first device. It's primarily done in Europe and Australia, and there's no fully approved device in the United States. There are a few centers in the world that are truly doing this. So if you look, this is on the left here, that's what Donna's femur basically looks like, okay? So when she puts her socket on, and many other amputees, actually she's not as bad as most, but the muscles pull the femur out to the side. So when she walks and puts weight, which is this arrow, that's how your weight goes, her bone shoves out the side of her thigh and hits that hard socket every time she takes a step. It's incredibly painful, okay? But what osseointegration does is aligns the femur with the implant and then allows their weight to actually be directed in a normal vector, okay? So they're able to walk in a normal fashion. And instead of having their leg, often when they wear these sockets, they'll get contractures because their legs are stuck like that. And they have to overcome that as well. And with osseointegration, they actually can overcome many of those contractures and be very functional. So this is a little bit, you can see the socket, and then the bone-anchored prosthesis allows us many things that we can do. There's a bone part and then a percutaneous part, and then we're able to fit a wide array of prostheses. One of the biggest benefits of this is osseoperception. And what that means is they're actually able to feel through their prosthesis, through their bone, okay? They can feel uneven ground. They can perceive, you know, where their foot is, that sort of thing. It allows increased mobility and function and may improve life expectancy in diabetics and vasculopaths. So patients who have vascular disease and diabetics, we do know that particularly in peripheral vascular disease, once they've had an amputation, they may be at higher risk or usually at higher risk of dying earlier because they become less mobile. They already have, are very ill. So if they are less mobile, they're now more likely to die at a younger age. So currently, osseointegration is for traumatic amputees and basically post-tumor patients, okay? There is a huge opportunity for patients. The vast majority of amputees in the United States are from diabetes and peripheral vascular disease. But currently, this is not indicated in those populations, but it's one of the things that we're going to be looking at, or we are looking at here at the University of Colorado. Again, diabetics are the 8 to 24 times more likely to undergo an amputation than non-diabetics. It's a huge patient population. This is a little bit about what it looks like. This is the press fit device. It has this porous area of the metal that is put inside the femur or the tibia, and then allows the bone to grow into these pores until the prosthesis or the metal becomes one with you, okay? The other components are this is the dual cone and this dual cone screw that then comes out the skin and allows us to fit a prosthetic to them. This is the other type of device that is currently available, and this is the screw type fixation that that is the birth of this technique that comes from the dental implant industry, okay? So this is what it looks like. So the first stage when we're talking about a transfemoral amputee is they're an existing amputee, as you know, and we open the residual limb, we ream out the canal, and then we're able to implant that device. It's a little jerky, but we're a lot more smooth than the OR, trust me. After 6 weeks, the implant is then integrated with the bone, and then we come back and do what's called the second stage, where we make a stoma or a aperture in the skin, insert this percutaneous component, and then we're able to fix the prosthesis to the patient, and they're able to walk for the first time in this manner. So what does it look like? So here's a patient of mine on the left who is a transtibial amputee, and we saw Donna getting ready to put on her prosthesis, right? Well, imagine getting up in the middle of the night and you're like, I have to go to the bathroom. What are you gonna do? So as an osseointegrated amputee, you just clip your leg on, right? Able to stand, walk, wear pants. So a lot of amputees can't wear pants because they're encased in this heavy plastic socket. So they're sweating and they're just all this energy to walk, right? So anyways, that's one of the things that they'll talk about. So here's Donna in the middle we've finally gotten her leg on, and this is what it looks like when she walks. So you can see she does not have a normal gait. Every time she steps, she feels the pressure in her groin and in her posterior side. She has to sort of pivot around to turn around. And this is an osseointegrated patient on the right. Her gait is incredibly normal. She's able to wear shorts, and one of the things that socket wearers will talk about is not being able to go to the bar and hang out or have dinner with their friends because they're sitting on this huge socket. So it's uncomfortable. And what they want more than anything is to just take their leg off, but it's not socially acceptable. So they just sort of sit like this. But it's a real thing, right? Like just being able to go out and enjoy dinner. Lady on the right, she just sits normally. So here's Donna's preoperative x-ray. And about 7 weeks ago, she underwent the first stage of osseointegration. And today, she had the second, okay? So this was her. She offered to come here tonight, but this was her just about 10 o'clock this morning. And I said, Donna, you can't come to this thing. You just had surgery. I want to go. I want to tell him this is going to be. So anyways, she's recovering, and she will walk for the first time on Thursday. So with her osseointegrated amputee. She's looking forward, she's like me, she likes horses, and so she can't ride horses with her socket. So one of the things that she's really looking forward to is riding horses, which I'm really looking forward to. But here's an osseointegrated amputee doing things you can't do as a socket wearer, okay? So riding a stationary bike, can't do it. Can't ride a motorcycle. Can't do a rowing machine. I don't like to do rowing machines either anyways, but you can't do that. So this is a really huge game changer. And we're partnered with our colleagues. Dr. Frolke is here from Holland. This is Dr. Van de Meet at Radboud University to try to bring this technology to the United States and this campus and help bring it to the next level. There's so much to be done, okay? There's so much opportunity. How can we make this more available? Some of the things that we're looking at is how can we make this more available to the vast majority of amputees in the world who are diabetic or have peripheral vascular disease? We're actively in the process of starting a clinical trial to make this readily available to patients in the United States, okay? There are so many opportunities for advancement in this field and this technology, for everything from the bone ingrowth to the design of the implants to the metal to how often the parts need to be changed to you name it. But one of the most exciting things that we're working on is regenerative peripheral nerve interfaces. So this is where we take the nerves that have been cut as a part of the amputation and then reimplant them in a piece of muscle that then it innervates this muscle basically like an amplifier, okay? So we can, with electrodes on the surface of the skin or electrodes directly implanted, we can then get the signals from these nerves. And when you think about moving your foot up, your foot may move up in the future, right? It may not be your foot, but it will be a myoelectric device, okay? That's where we're going with this technology. It's super exciting, okay? This was another patient that we did today, okay? And this was a custom designed implant where We took the patient's anatomy, this is his CT scan, and planned out very diligently exactly where we were going to cut his bone and design this implant tailored to him. So there's all sorts of opportunities for tailoring these implants. They're made for the patient. It's personalized. And there's all sorts of opportunity to figure out how can we wire these devices so that we can then use their residual limb muscles to function a working hand or an ankle or a foot, right? So, thank you. This would not be possible without a huge amount of help from a really awesome team. So, very privileged to be here on this campus and be able to work with all these people, including Dr. Dragoo and Dr. Berger, my colleagues. And we're trying to take away those stop signs that people run into in life. So, thank you.
So first of all, I want to thank you all for coming out on a Monday night, as I said in the beginning, especially in the winter. The second thing is that I want to say thank you to people like Don Ellerman, our chancellor in the back. Don, if it wasn't for your creative mind and for picking the right people and building this beautiful campus, picking the right dean, and giving us the opportunity, none of this would be possible. This is a magical place. This is a phenomenal place. You can fly as high as you want to, you can dream as high as you want to, and you can really deliver compassionate patient care because there's no obstructions from the School of Medicine, and we are just grateful to be at the cutting edge of technology in this day and time. So thank you again, and we're going to open up for some questions. Jason, would you like to come up?
I do have one question. We had talked about cell therapy and the slide about how our cells degenerate as we get older. And the examples shown were people that were much younger. If you look around this room, people like ourselves who are over 70, where are we for cell therapy for people like ourselves?
Well, it's a great question. You know, one of the things we looked at initially was the stem cell reservoirs we have in our body. And it's interesting, if you look at it, if you look at our bone marrow, where traditionally we extract a lot of cells for cellular therapy, that dramatically falls at the age of 60. And it's because our bone marrow is replaced by fat and other tissue within our bone marrow. But the interesting thing, if you calculate the same amount of cells within fat, it doesn't decrease substantially. And so then that is why we're just recognizing that as we age, there's certain cell reservoirs that will be maintained and certain ones that won't. So then if you are 75, you may be a candidate for a different type of cell therapy than when you were 30, but at the same time, there's still options. And then the other thing is that our cell reservoirs don't go away. There's less of the cells there, and they become more specialized. So instead of each cell being able to turn into 5 different type of tissues, maybe when we're older it turns to 3. So then we need to have more cells to be able to create tissue as time goes by. And that's the science we're working on now. But it looks as though, and we've had plenty of good responses in our trials to folks over the age of 70.
So we should all gain weight.
Absolutely. Eat like a king.
Oh, I've got a lot of stem cells.
So are there any current clinical trials for cell therapy?
Yes, there's plenty on campus, and plenty on campus for multiple different subspecialties in medicine. And I'll just tell you a couple of them. One is the David trial, where there's a hole in any of your cartilage areas to refill it. The other is osteoarthritis trials. So this is then the ones of the trials that there is a lot of loss of cartilage. So how much can we rebuild back? And we're actually measuring it. And just so you know, for the level of science, we can't be biased in this whole thing. I mean, we want it to work, but we need to report to you it actually works. So just to give you an example, if we take an MRI after you have your cell therapy treatment, we use special MRIs that actually quantitate the volume of your cartilage, and we send it to Europe. So we don't even look at it, because there we have an unbiased approach for them just looking at it completely independently to report back to us to measure the volume. Obviously, we're talking with you and keeping a lot of metrics on how you're doing and how you're feeling with the at the time. We're trials to build back your subchondral bone. We have about 7 clinical trials going on, and that's just the beginning of our regenerative medicine department that we're building here. So in its infancy, we have a lot. Check back in 2020, I would just say that it's going to be close to doubling that amount. And then what we're going to have also is a web page eventually where we can have folks who are interested in the clinical trials go to it. But of course, the gold standard now is clinicaltrials.gov, right? And you'll see plenty of my trials that are from Stanford. They're just being ported over here, so we just have a little bit of lag time for that, but plenty of activity. Ophthalmology, I think, is getting close to some, a lot of different areas, so a very exciting time.
How long do you leave that pipe in the femur there? Does that ever come out and get cleaned or anything like that, or is that just staying there forever?
Are you talking about the piece that goes in the second stage, that piece?
Was that upper bone is your femur?
Yes, sir. So that stays in for life.
It stays in there forever?
Yes, sir. So the goal is to have your bone heal into the implant, and you become one with it. So there have been cases where, with primarily hip and knee replacements, where patients have rejected or had a metal allergy. So one of my patients actually had this with multiple hip and knee replacements. So we have to do metal testing in those situations. There are some components that can be made that you may reject for that reason, but we would test that, and we don't anticipate that you would reject it.
There's been quite a bit of negative publicity.
Yeah, good question. I'll repeat it just because the microphone kind of went out there. You were saying that there's a lot of negative publicity with regards to stem cell research nationally, and the question is, what's the difference here at CU? I would slightly alter that maybe opinion in that the stem cell therapy and the clinical use of stem cells has a lot of negative reporting and a lot of media coverage for a very good reason, because most of it has no basis. And most of the procedures are done with are named cell therapy, and there's no cells even in the mixture at all. For an example, a common practice would be come into my office and do stem cell therapy, and what we're going to use is amniotic fluid. And the way that is produced, for the most part, contains 0 cells within it. But you see, it's reported to the patients and disclosed to them that they're going to have a stem cell therapy. And you see, that just needs to change. And so that is the negative part of what has happened. It's negative because it's cash pay, so then you could see how in the whole practice and different disciplines of medicine that can be taken advantage of, and it can be taken advantage of because of the hope of patients. There's many patients, as we have seen, that have been suffering, and they just want the hope, for something different, and it preys upon that. The difference is the science. So what's happening here at CU is we're the doctors doing the science and creating the techniques, and then we're the one delivering care. That's totally different than the other practitioners, let's just say even here in the Denver area. And we want the responsible use of this regenerative medicine. It's not to say that everything we're going to do will work. And if it doesn't work, we're going to tell everyone it doesn't work. But we're going to try to do so responsibly, because we start with the basic science and we take as many steps as practical, and then we say, hey, let's go forward and let's test this and give this a chance. And you see, the benefit of that. And so that's the big difference between CU and what you hear about in the media. Well, it is, this is going to be a unique program here that is different than any other, so that I'll say. But then there is certainly some other centers that are researching this and doing a very good job at it, and with a responsible approach. It tends to be more correlated with academic centers and the burden of proof that's acceptable for a center. So I think that would be a good start, and a different state is to look for those programs that are resident at the academic centers.
I have a question. If you're traveling and you have an artificial limb, do you have any trouble getting on an airplane?
That's a great question. So yes, the answer is yes. So frequently patients need to have wheelchair support as they travel. You will find that they are very preoccupied with what they have to take with them. So how much do I have to carry? I mean, these things are pervasive in their everyday existence. When some of our patients left after their first surgical procedure, they had to have some dressings and things like that, and we had to take particular care in how we packaged them to make them as minimal as possible so that they could fit in a backpack and things like that. So it's a challenge.
My question's for Dr. Berger. I couldn't quite tell in your picture what the implant was. Was it metal or is it biologic? And then second part, is there any work being done in regenerating discs themselves from individual stem cells?
So first of all, the implant is a titanium-based end plate, which also has a rough surface, just like the surface that Jason described, so it can have bony ingrowth. And then the piece in the middle is a high-density polyethylene glycol, so it's the same thing that's in a knee replacement. And it's been tested to withstand 30 million cycles. Yes, regenerative medicine is the one hope that is there for degenerative disc disease. At the moment, there is nothing, absolutely nothing that's proven, because every time you pierce the disc with a needle, you run the risk of actually causing disc disease. So you have to be very sure that it works. I've had multiple patients, unfortunately, come to me who also had stem cells in their discs. They end up with a significant inflammatory condition where they have severe pain in the nerves. And on an MRI, you can see that the bone above and below the disc are completely white. So there's a massive reaction. But all of these patients end up in excruciating pain if they don't get infected. So unfortunately, there is nothing at the moment. I'm sorry about that. I also want
I have a question for the two patients. Did your health insurance cover any of this?
Yeah, you got.
I can answer this one.
Yeah, you can.
Okay. Well, I injured myself on school grounds. So my school actually covered the cost of my procedure because I was enrolled in athletics. Yeah.
So I have Blue Cross Blue Shield of Alaska, and I cannot say how bad they are. I would never use them. Really, I mean, I'm not going to try to get political, but I think what we need in this country is everybody get their own bill up front. Then they can decide if they submit to their insurance, to the government, or pay it out of pocket. Because if I could do it all again, I would not go through my insurance and I would have just paid cash pay. Because it took that long for them to not only figure out my bill, but also I couldn't figure out my life because of the cost. Like I couldn't figure out how much anything costs. I couldn't figure out who's going to pay. I couldn't even because I would have just sat there and worked for years and then paid it myself out of pocket, than have to go through the process of trying to go through insurance. So
we have time for one more question here in the front here, and then you'll be here for, for more questions then too.
Hi. There was studies for the knee. I was wondering if there are any prospects for studies for ankles and elbows, shoulders.
Yes, and the way that research works in the sports medicine arthritis tends to focus on knees being the model, and it's because of numbers. And then after that, when there's a basically a burden of proof, then it goes typically to the ankle and or the hip, and then finally to the shoulders, where the amount of cartilage problems, et cetera, is much less. What you tend to see, and what is the truth, is that there's much more evidence for the knee than there is at any other joint, and then other joints will just lag behind because of a true numbers game, and that has to do with research and research dollars for it. But they'll eventually catch up, but as of now, by far more studies in the knee than any other place. Yeah, much less though for hips.
I want to thank you all, but I also want to do a shout out tonight to two of our PhDs in the audience, Doug Adams and Cheryl Acker-Bricknell. Would you please stand up? We recruited Doug from the Cincinnati, and I hope it's right, and Cheryl from Rochester, and they both brought in several millions of dollars of grants within the first 3 months here. And we have never been blessed to have a true research basic science lab. And it's when you build a program is not one person. It's bringing the science with the clinician, having the patient population, and having the passion. And so again, thank you everybody, because we're a team, and we hope we can make it better for our patients and for you all. Thank you very much.